So I'm on the spinous process. My right thumb is blocking the spinous process of L3. All right. As I bring work through the hips to abduct the hips to the right, my patient is prone. As I abduct the hips to the right, I'm inducing side bending right of L3 on L4. Notice on the left side, a up glide is occurring with L3 on L4, and a down glide is occurring on the right or the facet joints of L3 on L4. But I'm working from bottom up. Do y'all see that?
No.
You don't see that?
I don't see that. I'm actually very confused right now.
All right,
This
look
not
right
going
here.
down right here?
So look right here.
Yes.
This is L3 on L4.
Right.
Right? This is on the right side, L3 on L4. And I got the patient prone, and I'm abducting. I'm working through the bottom up with the patient prone to produce a side bending right.
Right.
But we know as we side bend right, we're gonna get an up glide right here on the left of L3 on L4. Can you see how things are opening up and a up glide on the left is occurring? But I'm working from the bottom up to achieve that. You see, and over here, a down glide is occurring on L3 on L4.
I'm looking at it this way.
Yes.
Okay. I was looking at it.
Do you see that?
Yeah.
Okay. All right. And so I use this technique to improve side bending right of L3 on L4. I can come right here and block L4, spinous process with my thumb, work through the hips to abduct to the right. And now what do I get with L4 on L5? What does that look like? There you go. Yes. So you get a down glide on the right, up glide on the left. So we know with side bending to the right, we're going to get a slightly on the right side. On the right side, yeah, I'm on the right side. So right side of L4 on L5, we're going to get a slightly posterior and inferior movement of the facets of L5 on L4, which ultimately is a down glide. On the right side of L4 on L5, we're going to get a slightly superior and anterior movement, which is ultimately a up glide, right? You see? The apex on this one, on Charlie over there, the apex put me at L3. Over here put you at L4. So you just kind of feel it out with your patient, and you can work from the sacrum up to localize L5, L4, L3, and thus forth. Okay? All right. Now, let's go around and show this the other way. Then I'm going to get Krista. Now, I'm on the left side. So now I want to work on lumbar side bending left. I want to improve that with this mobilization technique. So now I come here and place my left thumb on the spinous process of L3. I work through the hips and impart a left side bending. So what do I get on the right side? I get an up glide ultimately of L3 on L4 relative to moving from the bottom up. And I'm getting a down glide on the left side of L3 on L4. Does that make sense? All right. So you got to come visualize this and see what's happening. And when you see what's happening, then it opens up and it makes sense to you. All right. Now, let's go. I showed it on the right side with Krista. So now let's show it on the left. Come across. All right. Now, I'm going to say that my thumb is on L3 because L4 is going to be about right here, and then again 5 is going to be deep. I can't get to 5 most likely this the transverse process, but I probably can get to the spinous process. All right, come right here. What did I feel? I felt something. That was her muscle tone kicking in. Okay. Now I induce to the left, and I can feel that separation. I feel it right there. Yes. Do you feel that, Crystal? Mm-hmm. So I can feel this up glide of L3 on L4 occurring. I feel the space, I feel the gapping on her right side, right? There's gonna be some approximation or down glide on the left side. So this would help with side bending to the left, right? So can you visualize and see how she's side bending, lumbar side bending to the left? Mm-hmm. All right. That is good. Very, very good. All right. And so I can compare both sides. I can grade that using a Paris scale. You know, in Krista's case, she was normal. Okay. So she was symmetrical on both sides. I didn't feel any greater resistance or limitations compared to the other ones. All right. So yes.
Could you also use this as an assessment for rotation as well as the side bending? Because with every side bending, there's a reaction as well with the uplines and downlines.
So that's a good question. So Bella asks if you can use this to assess rotation as well. So now with that question, you will have to extrapolate. So we know that in the cardinal planes and the cardinal planes, so we know that with side bending, if I side bend to the left with lumbar spine, rotation has to occur to the right to get full side bending. So you can extrapolate and get a sense of what rotation is like. So if she's limited with rotation, side bending to the left, you can deduce that rotation to the right could likely be limited. You can deduce that from this, you see? So now you are extrapolating what you know arthrokinematically and what you know about non-functional movement and functional movement of the lumbar spine. Or some may say physiological movement versus non-physiological movement, all right? So now you extrapolate it now. So good, that's a good question, Bella. And that's the type of thinking you want to be doing, because you have to do that in the clinic, you have to do that on the National Physical Therapy exam. If she's doing functional movement, we know that side bending and rotation occurs on the same side in the lumbar spine for functional movement and or physiological movement, all right? So now then you can take that and extrapolate. So she would likely have, if she's limited with side bending to the left, if with functional movement, she could be limited with rotation to the left, with functional movement. You see?
Yes, sir.
All right. All right, that's good. And so the side that's towards the ceiling, which is the right side, we're working on improving side bending towards the side that's facing the ceiling.
Right.
So we're working on improving side bending to the right. And so as I work through the ankles and generate side bending towards the right, it's the left side that you're gonna get the up glide on, and on the right side, you're gonna get a down glide. So on the left side, you're getting an up, on the left side, you're getting an up glide of L3 on L4 occurring, and on the right side is producing a down glide of L3 on L4. But this is from the sideline position, okay? All right, so now I'm gonna get Krista on the table and show you all what that looks like on a person. So, all right, line on her. So I'm gonna bring her hips into flexion. So when I bring her hips into flexion and bias her into the lumbar spine flexion a little bit more, what is that gonna do right there?
Open up the
Yeah, so it's gonna distract.
Yeah.
So it's gonna open up the intervertebral foramen and cause a little bit more separation of those facet joints. So now, again, I'm using my anatomy coming across, all right? So my right thumb is blocking the L3 spinous process, and I'm gonna come like so and raise Crystal's ankle like this. So as you can see, as I'm raising her ankles like this, you can see the left side opening up. So you can see that relative to what I'm doing, there's an up glide occurring on the left side and a down glide occurring on the right side of L3 on L4 to improve or achieve side bending to the right, lumbar side bending to the right. Okay, so that's what's happening right now. And so this is a technique you can use with the patient and sideline. Once you get her there, then you can do some gentle oscillations. Okay. It's probably best to hold both ankles. And then if I want to do the opposite side, I would just turn her onto the opposite side and do it on the opposite side as well.
You said both of these techniques can be a soft tissue mobilization or a joint mobilization?
So these techniques, that's a good question. These techniques are specifically joint mobilization.
I think you really need to use both legs to be effective. I don't think you can get this as effectively with one leg. If you really had a patient that you were just felt like you physically couldn't. Do you guys remember the technique? I think we also did was straight through the pelvis. You guys remember that?
You may have to show them another Dr. Claire.
Just pushing the pelvis down. Okay, that is probably not as effective as using the legs, okay? But if that's the best you can do, it's another tool in your toolbox. Does that make sense?
Oh,
Like
yes.
I would go for this technique or the prone abducted leg, but if you're in a situation where that's just not gonna work for whatever reason, you do have some other tools.
So pushing the pelvis down would induce left side bending, right?
Correct, okay?
Pushing it up would be right side bending.
That's right.
Correct.
And then if you want to localize it, so say if you want to localize the technique to a segment, right? If I come right here and localize and block the L3 spinous process, and then I push down like that, right? Then we know that's gonna be side bending to the left, all right, of L. Would localize it to L3 on L4 if you want to add
Go
that.
until you feel a gap, right?
Right,
Yes.
You're going to feel a gap. Because what's gonna happen is you're gonna feel that gapping is gonna occur on that right side.
So it's the same technique, you're still blocking spinous process, just whichever side. So if I was gonna do the right side bending, is that correct? Yes. Here versus maybe I block on the opposite side of the spinous process to focus it.
You
Right?
only doing this if you can't lift their legs, right?
Yeah, I would still probably have a preference, but this one's probably easier unless you can't lift the person's leg. But I don't think you'll get it with just one leg.
All right, so next would be the long axis laminar release technique, which is a good soft tissue technique before doing any of these mobilizations at the thoracolumbar spine. So go ahead and practice those two.
And this is a method of building rapport. You're assessing as you go.
How's that feel?
But that does help
It hurts.
the patient.
This is a problem right here. So again, as I'm treating, because I was actually applying some pressure and glossing over it. So as I was doing this, I felt that rope bend. And so when you come, woo, same thing over here, but not as thick as this one. This one is thicker over here. Okay.
Krista, does it refer pain anywhere when he hits that spot, or is it just sore where he's at?
Just where he at.
This one, man. Let's see, I can feel it from my thumb. Let's see how far it goes. She doesn't like. So right here, it kind of decreases. So it starts right here. What's that?
You finna kill her.
So it starts around T6. This rotary bend. Breathe, Crystal. Y'all have to feel this. All right, it ends. It starts to end about right here. It's not as much resistance. So in my assessment, I would be like noted increase muscle tone in our hyperactive muscle tone or top connective tissue bands on the left side from T5 probably down to T10, T10ish. And I would just revisit it. And then it causes nociceptive, I'll probably notate that it causes nociceptive startle response that is uncomfortable to the patient. So this side over here is much less tone, much less resistant, but she does have rotary band right here. Yep, she has it over here too. So I'll probably give her some I'll probably do soft tissue work on her. I will do soft tissue work on her. I'm not gonna say probably. Then I'm gonna try to elongate this area right here with some, what do you call it, cat-cow? So I'll probably have her doing some of that. And everything I'm probably gonna have her doing is probably gonna try to elongate this area a little bit more and stretch these soft tissue structures out to try to decrease her tone.
Would you do dry needling on something like that?
Yeah, if I was dry needle certified, I'll probably dry needle it. But I'm not dry needle certified, so in my clinic, I use what they call acupressure with heat. So I do some acupressure with heat. Acupressure. Acupressure. Type in your